And RTA is part of differential diagnosis of a number of pediatric endocrine conditions. Unfortunately, it's a non-specific presentation. So often there may be confusion in terms of diagnosis. So when we talk about the acid-base regulation, we are basically talking about the excretion of proton and bicarbonate, which are there in that perspective. So kidneys play an important role in regulation of both excretion. The other organ which regulates the acid-base balance is the lung, which is predominantly talking about the carbon dioxide excretion. So proton, as we'll discuss in some detail later on, is essentially secreted in the urine. You will not be able to get the proton in the urine. You have to push it against a gradient. So it requires a lot of energy. This is done by the kidney. It's a complicated process. A lot of energy is required. So you will only be giving 1 millimole per kg. That will be there. Any proton which comes to the urinary tract lumen will go back again. So the main problem then is to really sequestrate it using ammonia so that ammonium excretion becomes significant. So it's actually ammonium and not proton, which is a marker of urinary acidification. Now, the second agent is bicarbonate, which is much more easier in terms to filter. So essentially, a lot of bicarbonate is filtered every day. So for an adult, we are talking about 4,000 millimoles per day, approximately 70 millimoles per kg per day. So it's like a huge amount of bicarbonate which is filtered, but most of it is reabsorbed. So only 1% will be excreted. So now if you think about it, you are acidifying by two mechanisms. One is that you are basically pushing off your amount of proton so that you don't have too much acid in the blood. And second, you are reabsorbing the bicarbonate. Now, if you have a problem in the acidification of urine or in bicarbonate reabsorption, you will have acidosis. Now, which of these will be more difficult to treat? Not in severity in terms of when you're replacing, what will be the most difficult to achieve a good bicarbonate level? You will need much more amount of bicarbonate. Of course, in terms of severity, and I'll talk about that if you have a filtering defect, a reabsorption defect, if your bicarbonate goes below a particular level, you will not be excreting it. So therefore, it will be a self-limiting condition. So proximal RTA, as we'll discuss, is a self-limiting condition. However, as soon as you bring the level to a higher level, you will have this bicarbonate urea happening. So it's difficult to treat, yet it's not very severe. Distal RTA is more severe, but it is easier to treat. The amount of bicarbonate required is much less in that perspective. So 90% absorption happens in the proximal tubule. So bicarbonate, as with many other things like sodium, potassium, glucose, this is all freely filtered via the glomeruli, and all of which will go into your proximal tubule. Now, proximal tubule is the major source of reabsorption of all these contents. And this reabsorption basically will result in absorption of more than 99% of your bicarbonate will be absorbed using the carbonic anhydrase, which is there, and the sodium bicarbonate transporter. So it's like a co-transporter transport. It's not a very, very active transport except for the carbonic anhydrase. Now, 90% of bicarbonate is absorbed here, and around 10% will be absorbed in the distal tubule. Along with bicarbonate, the proximal tubule is a major site of absorption of water, glucose, phosphorus, amino acids. So a lot of things are also absorbed here. So you will have a phosphorus, amino acid absorption. So if you have a generalized defect in the proximal tubule, you will have glucose urea, phosphate urea, amino acid urea, besides having a metabolic acidosis. However, if you have a problem specifically in the sodium bicarbonate transporter or the carbonic anhydrase, you will have an isolated proximal RTA, which we'll discuss a bit later, which Dhani will talk about in that regards. And glucose is also lost here. So glucose urea is often a easily identifiable marker of proximal RTA and is often missed. So whenever you look at urinary routine examination of a child with failure to thrive, always look for glucose, because we will see often miss. I've seen many times it was there, but it was missed. This glucose urea was missed, and then RTA was not diagnosed in this scenario. Now, as I said, 10% of bicarbonate is largely absorbed, 9 to 10% at the level of distal tubule, and only 1% of it is really excreted. Now, proton handling is a more difficult scenario because proton is actually an acid. So when you are putting acid inside, you will need to be careful. It's not an easy process. You need an active transport there. So you need two major transporters, the potassium ATPase and the proton ATPase. So it's being transported in lieu of potassium or directly pushed here. And this provides a huge gradient. So actually there is a 250 times higher level of concentration of proton, which you can achieve in the lumen with the help of these active transporters. So they play a big role there in that regards. Now, the problem with proton is that if you keep proton here, it can easily go back because there is a big gradient. So now you have created a gradient. If there is a gradient, it will go back into the circulation, and again, you will not be able to carry it forward in the urine. So what body does in this scenario is to produce ammonia, and this renal ammonia reacts with the proton to produce ammonium ion NH4 plus, which basically is the one which takes the proton along with that. So any condition in which your ammonia production is defective, you will not be able to acidify, and this will result in decreased proton loss, and you will have an issue in terms of proton excretion. Now, which of the electrolyte inhibits ammonia production? And what will be its implication? So if your potassium is high, yeah. So when your potassium is high, and we know that proton and potassium are antagonistic. When you talk about cellular exchange, if your potassium becomes more, it goes into the cell, proton comes out. Similarly, if you want to excrete potassium, it has to compete with proton. So what potassium does very opportunistically is that it is really inhibiting ammonia. So then proton cannot go out, and then potassium will go out. So anybody who has hyperkalemia will have metabolic acidosis. Anybody who has metabolic acidosis should have hyperkalemia, and that is the basis of quote unquote type 4 RTA, as we'll discuss subsequently in that regards. So then you will have excretion of around 1 millimoles per kg per day, which means that once you have corrected the initial deficit in terms of the acid level, you can then give only 1 to 2 millimoles per liter per day, kg per day of bicarbonate, and that should be sufficient in distal RTA. So as I said, distal RTA is more severe, easy to treat. Proximal RTA is less severe, difficult to treat in that regards. Potassium, as I said, is very, very closely linked to this whole process, and potassium abnormalities may be the first sign of identifying these disorders. So potassium basically again is mostly absorbed at the level of the proximal tubule. And whatever potassium that appears in the urine is because of the issues in the collecting duct. So you have this epithelial sodium chloride channel, which basically takes sodium outside the lumen. And once you take sodium outside, you will also take chloride along with that. Now, the chloride lags, the speed of chloride resorption is lower as compared to sodium. So therefore, you will have a negative environment here. So now you have an electrochemical gradient for potassium. So potassium can now enter into the lumen. So effectively what you're doing here is that you are exchanging sodium for potassium. So any condition where your sodium delivery in the distal tubule is more, you will lose potassium and you will have hypokalemia. So if you have, let's say, somebody who has RTA, you give them soda bicarbonate, what will happen? So if you are giving sodium here, you will have exchange here. However, if acidosis, if you have intracellular acidosis, that is also going to cause potassium loss. So in distal RTA, if you correct that intracellular acidosis, this potassium may improve over time. Now, as discussed, this proton will be excreted along with ammonium, and this proton and potassium have an antagonism, so to speak, in terms of this scenario. Hyperkalemia, as I discussed, inhibits ammonia production, therefore reducing proton excretion, causing mild metabolic acidosis in that regards and in that scenario which happens in that regards. So anybody who has acidosis, what all should they do? So of course, if you have acidosis, you would want that you are going to have a good bicarbonate absorption. So in the presence of metabolic acidosis, your Fe bicarb should be less than 5%. The second scenario is that your ammonium production should be more, which means that when you talk about urinary anion gap, you will have a lot of ammonia in the urine. So the urinary osmolar gap and the urinary anion gap, which I'll talk a bit later, should also be positive. So that is a normal response in that scenario. And then, of course, you should have a acidic blood and an acidic urine. So the normal response is to have acidic urine. You will expect potassium loss to happen in that regards. Now, in this perspective, if we talk about the pathophysiology of RTA, you can broadly have problems either in the proximal tubule or in the distal tubule. As discussed, proximal tubule is a milder disorder. As soon as your bicarb becomes below 15 or 13, you will not be filtering bicarbonate, and therefore there would hardly be any further acidosis which will be there in that regards, and you will have an acidic urine. There will be no renal calcification. The reason for that is that you have got specifically citrate which is also being lost, and because of the loss of citrate, you will have preventive measure which will happen in that regards. Now, as far as distal RTA is concerned, the problem predominantly is in the distal tubule in terms of acidification. This is a more severe disease with alkaline urine and calcifications which are more common in that regards. Then you can have a problem of type 4 RTA, which is not really a renal problem. It's more of an aldosterone problem in either aldosterone production or action, and that can cause hyperkalemia, metabolic acidosis to a milder extent, which is there in that regards. So this is the overall pathophysiology. As far as the RTA is concerned, we will now move forward more in terms of the etiological aspect.
Thank you, sir. So once we have established that we are dealing with a renal tubular acidosis, so the necessary components are metabolic acidosis, which is normal anion gap, of renal etiology, of renal tubular etiology. So your renal function test should be normal. We need to know whether it is, what type of RTA is it, to know what management needs to be given. The most common one, as sir has already said, is type 1 or distal RTA. It could be either congenital or acquired forms. Congenital or the genetic forms of distal RTA could be autosomal dominant or autosomal recessive mutation, and acquired could be because of structural kidney disease, obstructive uropathy, secondary to autoimmune condition, and drug-induced distal RTA. The primary pathology here is defective acidification of urine, and therefore there is alkaline urine, more severe metabolic acidosis. It is an isolated condition, meaning that no other molecules or ions are lost as a result of distal RTA, and it is associated with nephrocalcinosis or urinary stones because there is no citrate-urea happening in distal RTA. Next is type 2 or proximal RTA. Again, this could be genetic or acquired. The genetic forms of proximal RTA could be either an isolated problem in the sodium bicarbonate exchanger or a generalized tubular dysfunction result, as may be seen with cystinosis, tyrosinemia, GSD, and galactosemia. Acquired causes of proximal RTA include drug or toxin-mediated injury, as may be seen with acetazolamide overdose or heavy metal poisoning. Type 4 or hyper, these conditions have the primary pathology here is excessive bicarbonate loss, and as we already know, it is a self-limiting condition. So the urine stays acidic as the distal acidification process is intact in this condition. It is self-limited, and as we've already seen, generalized tubular damage will cause Fanconi syndrome. No calcification is seen in proximal RTA because of citrate urea that accompanies. Type 4 or hyperkalemic RTA is because of voltage gate defects or RAS defects. It presents with a milder tubular acidosis with hyperkalemia and low sodium. So we've already seen the pathophysiology of distal RTA. Let me quickly revise it for you. So in the distal convoluted tubule, you have the proton potassium ATPase and proton ATPase channels. These channels are responsible for active transport of proton into the tubular lumen. Transfer of proton into the urine is responsible for acidification. Defect in these channels will lead to reduced acidification of urine. Moreover, there is another pathology, which is the back diffusion of proton because of the high gradient, which is again responsible for reduced acidification of urine. So here the urine is alkaline And since the proton diffuses back, there is low concentration of ammonium ion. All kinds of RTA will have hypercalciuria, but in the absence of citraturia and distal RTA, you will see nephrocalcinosis and urinary stones. Interesting is potassium homeostasis in distal RTA. So as we've already seen that potassium and proton have an antagonistic action. In RTA, because you cannot exchange sodium for proton, you will end up losing more potassium in urine to exchange for sodium. Moreover, these children also have an occult volume deficit, which results in RAS activation and exacerbation of this hypokalemia. You will try to conserve more sodium in this volume depleted state and end up losing more potassium. So there is reduced proton excretion in distal RTA, and because of RAS activation, you end up losing more potassium, resulting in hypokalemia. So this hypokalemia in distal RTA is often present at outset and maybe the pathognomic thing that will help you in clinching diagnosis. Interestingly, with soda bicarb supplementation, there is resolution of acidosis and improvement in hypokalemia. SLC4A1 defect is an autosomal dominant form of distal RTA, which is due to defect in the anion transporter, anion exchanger, that is the chloride bicarbonate exchanger molecule channel. It results in mild acidosis, has a later presentation, is associated with nephrocalcinosis. And since this channel is also present in the RBCs, it is defect in SLC4A1 results in spherocytosis. The more dangerous one or the more severe one is the ATP6B1B1 defect. Here the defect is in the proton ATPase channel. And as we've seen with the classical pathophysiology, so there is proton secretion defect. These children present with early onset distal RTA, more severe clinical manifestation, and they have associated sensorineural hearing loss. Obstructive uropathies are funny in the way that they may present with picture like distal RTA or type 4 hyperkalemic RTA. These usually have classical polyuria and a milder acidosis that may be seen. Drugs that cause distal RTA commonly are amphotericin B. Now, the major mechanism of causation of distal RTA with amphotericin B is the tubular injury, which results in creation of iron permeable pores, which cause more back diffusion of proton back into circulation. Next is topiramate, which is an anti-epileptic drug. Here the problem is inhibition of carbonic anhydrase, which results in reduced H plus secretion. Lithium again causes cellular injury like amphotericin B and more back diffusion of proton. Autoimmune cause of distal RTA should especially be considered in someone who's presenting at an older age with features of distal RTA, especially around adolescents. Common autoimmune conditions that may be associated with distal RTA are SLE and Sjogren syndrome. The pathology here is presence of carbonic anhydrase antibodies, and diagnosis will be established by the classical features of Sjogren and SLE that you may see in the patient, and ANA profile will guide towards the final diagnosis. Moving on to proximal RTA. Now, the primary pathology in proximal RTA, as we all know, is bicarbonate uria. This could either be an isolated problem wherein the sodium bicarbonate channel is affected, or a diffuse or proximal tubular injury, which will result in glucose uria, phosphate uria, and amino acid uria along with your bicarbonate uria. As we've already seen that the threshold beyond which there is a threshold beyond which bicarbonate will not be filtered. So once your bicarbonate falls to 12 to 15 millimoles per liter, beyond this value, your bicarbonate will not fall and your acidosis will be self-limiting in proximal RTA. Since the distal acidification is intact, your urine pH will be less than 5.10. This is what differentiates proximal RTA from distal RTA. This is an interesting condition of proton ATPase maturation where it is delayed maturation. It is a transient self-limiting form of RTA. Usually, children present in the infantile age group, and with maturation, they improve by childhood period. They respond very well to bicarbonate therapy. Now, like the SLC4A1 defect that we saw in distal RTA, we have the SLC4A4 defect in the autosomal recessive kind of proximal RTA. Here, the problem is an isolated sodium bicarbonate channel. Since it is isolated, you will not see glucoseuria, amino aciduria, and phosphaturia. The manifestations are early onset proximal RTA like picture, and the children may also have cataract, band keratopathy, and enamel hypoplasia in this condition. Fanconi syndrome is a diffuse proximal tubular injury wherein you're losing everything. And the common conditions associated with Fanconi syndrome are Dent syndrome, cystinosis, tyrosinemia, Wilson, Gault, hereditary fructose intolerance, Loeys syndrome. Proximal tubular dysfunction due to drugs, again, if you think about it, it will cause a Fanconi-like syndrome because it will cause cellular damage in the proximal tubular cells. Commonly implicated drugs are the aminoglycoside, your gentamicin, tobramycin group of drugs, anti-cancer drugs like ifosfamide, cisplatin, or heavy metal poisoning like lead, mercury, and cadmium. Hyperkalemic or type 4 RTA is unique in that there is actually no renal injury. It is a defect in the RAS axis that is happening here. The primary problem here is a reduced sodium load at the distal convoluted tubule, either because of extremely low sodium diet or because of problem in the RAS axis. Now we know that in the distal tubule, sodium is exchanged for potassium and proton. So when the sodium delivery to the distal tubule is less, you will lose less potassium in urine, you will lose less proton in urine. So you will have hyperkalemia and metabolic acidosis. And as we all know that potassium and proton have antagonistic function. When the body is faced with losing both of these, it will prefer losing potassium over proton, as hyperkalemia has more acute lethal effects in comparison to metabolic acidosis. So although type 4 RTA has hyperkalemia, it will not be really very severe because it will ultimately be lost. And as potassium and proton are competing, potassium is lost more, there will be less NH4 plus in the urine. So there is low sodium load due to RAS defects, hyperkalemia and acidosis, and low ammonia in urine in type 4 hyperkalemic RTA. As a result, urine pH is greater than 5.3 here. Now, the common conditions associated with type 4 RTA are hyporenism that one may see, problems in the ACE inhibitor or axis, so ACE inhibitors and angiotensin receptor blockers, problems in the mineralocorticoid production, so adrenocortical defect or drugs that may cause that may affect the mineralocorticoid synthesis, aldosterone synthesis, that is defect in the aldosterone synthase enzyme, or a blockade at the level of mineralocorticoid receptor or ENaC channels, which may be either acquired or congenital, like pseudohypoaldosteronism, the autosomal dominant and autosomal recessive forms. Common drugs affecting the aldosterone axis may also result in type 4 or hyperkalemic RTA. Common drugs that may cause are beta blockers, NSAIDs, and cyclosporin, which cause hyporenism. Angiotensin receptor blockers, which basically act on the angiotensin 2 receptors. ACE inhibitors, which prevent conversion of angiotensin 1 to angiotensin 2. Heparin, which blocks the mineralocorticoid synthesis in the adrenal gland. The spironolactone mineralocorticoid receptor antagonist, and amiloride, which acts on the ENaC channel.